Hello friends, Dr. David Katz back from a lovely vacation with another COVID reality check. I feel obligated to address the fact that it's almost October 1 as I record this. And a month ago, I extrapolated from the experience in New York City in the Northeast and suggested that the pandemic in the United States might very well be over on or about October 1st. That begs the question, was I right or wrong? Are we there yet? And what I'm going to tell you is I don't know if the pandemic is over, and neither does anybody else. And in some sense, that's good news because it does hold within it the hope that it actually could be over. Despite all the doom and gloom you continue to hear, I definitely think it's possible that the pandemic is over. But in order for us to take stock of my extrapolation, what we need to talk about is, first of all, what does it mean for it to be over? Why might I be wrong? I just extrapolated from the experience we were having in the Northeast. How might that fail to predict what happens in the rest of the country? But then I also want to talk about why, despite the doom and gloom news reporting, it actually could be over in the United States and we wouldn't necessarily know. And then I'll tell you where I think we land with that. So first of all, what over means is not 0 deaths, 0 cases, that SARS-CoV-2 disappears. That's unrealistic. It's never going to disappear. And by the way, I will, as I always do, attach a link below this video to a really detailed column. This was a hard one to write on this very topic that I'm actually just completing as I work on the video, but I'll post it before the video goes live so you'll have access to it. And I explain in detail there that I won't go into here that, basically once any pathogen establishes shop in a human population, it never goes away completely. The only exception to that in all of history is the one disease we intentionally eradicated, smallpox. But every other infectious disease, short of a global effort at eradication, sets up shop and never goes away. If we go out looking for SARS-CoV-2 in asymptomatic people, we'll find it forever. So that cannot be the benchmark for when the pandemic ends. Nor can lack of death, because we're mortal. People get old and die, with or without SARS-CoV-2, with or without a pandemic. So, essentially what we need to be looking for is no difference in the rate of death with SARS-CoV-2 in our population from what it was before. So in other words, people may occasionally die of SARS-CoV-2 infection, but it's instead of what they would have died of anyway, because people in their 80s die routinely in the United States. One of the things that's been obscured during the pandemic is that 8,000 people die on average every day in the United States of miscellaneous causes. 2.8 million people die in this country every year of miscellaneous causes. 1,800 people die in the United States of heart disease alone every day. All of that's been obscured during the pandemic. So no, all deaths won't go away. So the operational definition of over needs to be receding into the background noise of epidemiology. I want to quickly note why it can be so hard to tell that a pandemic is over. As I record this, it does seem very likely that the pandemic is over in Sweden. But even Sweden is encountering all sorts of naysayers and doubters, and, well, maybe it's not reliably over, maybe it will come back. Well, maybe it will. Nobody has a crystal ball, but it sure looks like it's over. They didn't do lockdown. Pretty much the whole population was exposed at one level or another. They have a negligible number of new cases. But even in Sweden now, they're still reporting deaths from COVID. Well, how can they still be having deaths if the pandemic is over? Because deaths occur after severe infection, and severe infection routinely makes people sick for weeks before it kills them. Sadly, many people have a weeks-long struggle in the hospital before they ultimately succumb to COVID. So in other words, people dying of COVID now in Sweden got infected weeks and weeks ago, maybe a month ago, maybe more. And so the deaths being reported now, they're very few in number, but they tell us almost nothing about the current state of viral circulation. They tell us about the state of viral circulation after a delay of 4 weeks, 6 weeks, 8 weeks. So even in Sweden, where it does appear that the pandemic is over, we have uncertainty. So that much more so in the United States, where we're a vastly bigger country, we're a vastly more diverse country. We've had a vast range of regional responses to the virus, state level responses to the virus. No wonder I can't say for sure whether I was right or wrong. And by the way, I readily admit I could be wrong. I could be wrong about everything. I'm simply telling it to you as I see it. I'm doing the best I possibly can in a massive sea of information to keep up with what I think are the salient particulars, try to interpret them rationally without a fixed agenda, and share those perspectives with you. That's what I'm doing here. I could be wrong. Absolutely could be wrong. I don't really think I am, and I'll tell you why in a second. But first, here's why I could be wrong. When you extrapolate, and again, I made it very clear in my prior video and my prior writing on this topic, I was not making a prediction. Prediction is you look at how the stars and planets align and try to predict the future. I wasn't trying to predict the future. I was looking at precedent in New York City, in the Northeast. What happened here? How long did it take for us to ramp up and develop a high caseload? What happened in our hospitals, where, as you know, I served as a clinical volunteer? What happened then during the period of the peak? When did we come off the peak? When did case counts start coming down? And if that experience was replicated around the country, what would it look like? So it was an extrapolation. But I could have been wrong for two reasons. First, my inferences were that in New York City and the tri-state area, Connecticut, New York, New Jersey, Connecticut, the area around New York City, that because lockdown came too late, pretty much everybody in this area was exposed. And that's true based on federal policy or lack thereof and state policy. But here's what I don't know. Maybe there were a lot of really nervous people, older people, people with chronic disease, who didn't wait for the state to take action, didn't wait for the city to take action, certainly didn't wait for the feds to take action, and they sheltered themselves away. What if a very high number of people in New York City and the surrounding area locked themselves down before ever the state did anything, before ever the region did anything? Well, in that case, there would be a lot more people in this part of the country still vulnerable to the virus than was obvious to me or anyone else. And as they come out to the world again now, we could have another surge even here in the Northeast. We're not seeing that. We're not seeing high demand on our hospitals. We're not seeing a rise in mortality. That doesn't seem likely. It does seem likely that the lockdown came too late in this part of the country, that we were exposed during a surge last spring, and that things have been better ever since. But one way I could have been wrong is if individuals did a better job of locking themselves down than states did. And then I'd be wrong about our level of exposure in this part of the country. So that's one way I could have been wrong. I don't think that's the case, but it's a possibility. The other way, so that's essentially the index population. The population I was comparing the rest of the country to was New York City and the Northeast. So I could have been wrong about the index population. I could also have been wrong about the comparison population. My argument there was, okay, the surge in New York City, in Connecticut, where I live, this part of the country, came in March, April, and then we got over it. And we had high-level exposure, and the pandemic is mostly done here. But in the rest of the country, lockdown came in time to prevent that early surge, but then the liberation came too early and it was far too haphazard. In other words, the problem wasn't the original lockdown, the problem was the return to the world. It was mishandled. And so my inference there is that around much of the country, when we started seeing surges every place other than the Northeast, it's because pretty much everybody came back out to the world indiscriminately. But I could also be wrong about that. What if a lot of people in Florida, Texas, Alabama, Kentucky, and every place else in the country who were concerned about their personal risk carefully avoided returning to the world and shielded themselves from the virus? So basically, there are two ways I could be wrong about the level of our exposure. And the level of national exposure is a critical consideration as we try to take stock of where are we now. Maybe exposure in the Northeast wasn't as great as I thought, because people took matters into their own nervous, anxious hands right at the start and sheltered away from the virus here. Or maybe they did that in the rest of the country when states opened back up. Those are the two major ways in which my extrapolation could have gone awry, and I could be wrong about October 1, which as I record this is coming in hot tomorrow. But I don't think so. And the main reason that I think the pandemic is mostly over in the United States is mortality data. Everything about our testing data is unreliable. Seroprevalence is partly based on how well the tests perform, which measure we're using for immunity, and what segment of the population we test to begin with. So a lot of what you're hearing about seroprevalence and what it tells us, unreliable. It's a source of information. It's a potentially useful source of information, but like all sources of information, only in context. The single most reliable source of data we have about the pandemic is mortality. It's the hardest thing to overlook. We notice when people die. Right? Let's be clear. And so we may be wrong about the total numbers of people dying of COVID, because some people were saying are dying of COVID actually would have been dying of something else even without the pandemic, so it's not really a COVID-related death. And in some cases, we're missing deaths that should be attributed to COVID, but those are rounding errors. Mortality is the most reliable source of information during the pandemic. We don't tend to miss that. And so we can have a great degree of confidence about the basic infection fatality rate around the world. It's informed by COVID-related mortality data from all around the world and from many countries that have done a much better job gathering data than the United States ever did. And in my prior video and in my prior writing, and all of that's referenced here again today below, I've done the math where if we simply apply the well-established infection fatality rate to the United States, we reverse engineer the denominator. If 210,000 people in this country have died of COVID, how many need to have been infected for our mortality experience with this bug to be anything remotely like other comparable countries around the world? And the answer is about 70 million Americans have been infected. So that is reliable information source one. Feel very confident about that. And by the way, even with extremely high levels of exposure in the United States, we still have a higher level of mortality per million population than Sweden did with no lockdown at all. If everybody in the United States had been exposed to SARS-CoV-2, everybody, 330 million people, our mortality rate per million population is higher than Sweden's. So if anything less than our entire population has been exposed, we're having a significantly greater mortality impact than Sweden is, and that starts to become really hard to explain. Okay, Americans are maybe less healthy than Swedes, so a slightly higher mortality impact, but basically the health of the populations is not that different. There's no particular reason to think that SARS-CoV-2 prefers killing Americans to Swedes. So really the only way we have any basis to understand the mortality experience in the U.S. is to either infer or calculate, and both approaches lead to the same conclusion, that a very, very large percentage of the American population has been exposed. So again, just using the infection fatality rate, 70 million Americans have been infected. There's another pretty hard fact, and that is lots of information sources in prestigious peer-reviewed journals tell us that about half of people, and maybe many more, but about half reliably, who get exposed to SARS-CoV-2 do not get infected because of native resistance based on prior exposure to common cold coronaviruses, and I've done videos and columns on this topic. Okay, well then if 70 million of us have been infected, based on what we know about the mortality, and if half of those exposed don't get infected, that means 140 million Americans have been exposed, half infected, half not, but that whole group now is relatively resistant. But then there's another critical consideration. We're a population of 330 million people. If 140 million of us have been exposed, it means 190 million of us have effectively sheltered ourselves away from the virus. Okay, good. I find that hard to believe, considering how inept our policy guidance has been in this country, that 190 million of us managed to stay away from the virus. But let's assume for the moment that that's true. So, the math based on infection fatality rates from around the world indicates 70 million American infections, plus another 70 million American exposures without infection, because 50% of those exposed don't get infected around the world. But of the 190 million who managed to hide away from the virus effectively, if you believe that, well, half of them have native resistance too. Native resistance doesn't depend on exposure. What native resistance means is half the population, half of the entire population, has prior exposure to common cold coronaviruses, has T cells that are reactive against SARS-CoV-2, doesn't have IgG antibodies, but is resistant just the same. So these are not people who show up on seroprevalence studies, but they have a native resistance. It's half of the whole population. So it's not just half of the 140 million who've been exposed. It's also half of the 190 million we're now saying maybe weren't exposed. That's another 95 million people. Let me just do this very simple math then. 70 million people infected, which is really necessary to justify the fatality rate we've seen here. Another 70 million exposed but not infected, and that's strongly suggested by global data saying half of those exposed have native resistance, don't get infected. Plus 95 million, half of the population that maybe wasn't exposed but also has native resistance. 70 plus 70 plus 95 is 235. 235 million Americans who have now either developed immunity because they've had SARS-CoV-2 or had prior native immunity, at least partial, because of exposure to common cold coronaviruses. That's 71% of the U.S. population. The most pessimistic projections I've seen about the requirements for herd immunity are about 70% of the population needs to be immune, and then we're there. Well, 71% is more than 70%. And this is not math I've tortured. These are big, blunt, flagrant numbers. Again, all I'm saying is that if the infection fatality rate is even remotely comparable in the U.S. to other developed countries around the world, we can't possibly have had 210,000 deaths out of a mere 7 million infections. That makes our fatality experience an order of magnitude greater than all of the European countries. It makes no sense. So for it to be remotely comparable to our peer countries around the world, it's not 7 million cases in the U.S., it's 70 million. And it's a robust, well-established fact of the pandemic that there's a lot of native resistance and that a lot of people who get exposed don't get infected. That's been backed up by seroprevalence studies on cruise ships, on Navy ships, in countries around the world, in New York City. And we have every reason to think that whether you're exposed or not exposed to SARS-CoV-2, that the likelihood of you having native resistance is about the same. So the math is that simple. 70 million infections, 70 million more exposed but not infected, and half of the unexposed population natively resistant. That's 71% of the U.S. population. And if that simple math is reliable, we're at herd immunity. And that means the pandemic is mostly over. Now, the other thing is that we are hearing about cases, spikes in cases around the country, but overwhelmingly we're getting the news it's in young people. Now, of course, inevitably, given how everything about the pandemic is hyped, we're getting a doom and gloom version of that. The sky is falling, young people are getting it, they're going to transmit it to older people, and we're going to see spikes in deaths and hospitalizations, but we're not. We're not seeing spikes in deaths and hospitalizations, and that may be because the vulnerable people have already succumbed in this country. That's what the fatality data suggest. It may be because those who are vulnerable understand their vulnerability, which is a good thing. They're being really careful. So, I hope my 80-year-old parents remain very careful about all this until we absolutely, positively, reliably can sound the all clear. So it may be a combination of factors, but the fact that we're finding lots of cases, asymptomatic cases among young healthy people, should be no surprise. First of all, we didn't do anything remotely like this level of testing back in the beginning. So if you go out looking for asymptomatic infection in large populations of young people interacting pretty intimately on college campuses, you're apt to find it. Here's the other thing, and I've done prior video commentary and columns on reinfection. We don't know a lot about reinfection yet, but what we do know tells us that People who are prone to reinfection with SARS-CoV-2 are mostly people who had mild infection the first time around. So we've got studies showing that if you had a severe infection the first time around, you have persistent levels of IgG antibodies, protective antibodies, for months. But if you had a mild infection the first time around, you don't even make IgG. You're basically fighting the virus off without it going that deep into your immune system, if you will. And so reinfection has been reported in people who had mild infection the first time around, or even asymptomatic infection the first time around. And then reinfection, so far, looks like it tends to be milder still. So somebody who had a mild enough infection the first time not to make IgG can get it again after months, but has partial resistance from the prior exposure and has an even milder version. So what if these college students that we never tested, by the way, back in February, March, it was March when we sent all the college students home. We didn't test them then. What if many of them had been exposed to SARS-CoV-2 then, but we didn't test them? We didn't know. What if many of the cases we're finding on college campuses now are reinfection? It's perfectly plausible. But we didn't look then, so we didn't find them then. We're looking now, so we're finding them now. But this could go on forever, because after months, these kids could get it again and get it again. Like the common cold, we can get it over and over and over again, but it's just not a very serious disease. We are actively looking for asymptomatic cases of COVID. We didn't do that in the beginning of the pandemic, and we're finding it. But we're finding it overwhelmingly in young people. I have argued in my prior videos and columns that winning this battle, getting to the end of the pandemic, is high case counts, low casualty counts. And I define casualties not just as death, but severe cases of COVID resulting in hospitalization, long-term complications. Any really bad case of this is a casualty. So winning is high case counts, where people get through this without suffering any harm and develop immunity. And we avoid the casualties because the vulnerable people are protected. And that, I've talked at length in prior videos and columns about who's vulnerable, so I won't go into those details here. It looks like that's what's going on now. So yes, young people convening on college campuses are often testing positive, but most of them have no symptoms at all. We're only finding it because we're looking for it. We're not seeing spikes in hospitalization for the most part yet. Those are declining nationwide. The medical system is not overwhelmed. I'm not hearing from clinical colleagues about being beleaguered as I did at the beginning. I'm also not hearing in my own personal network about severe cases of infection, which I absolutely did at the beginning. So friends, family, I was affected by this just like you. I was hearing about people near to me who were hospitalized with COVID. I haven't heard about a case like that in months. And then I have my extended social network. So I was hearing not just about my friends and family, but friends of friends and family of friends. And I'm hearing about none of that. So out in these concentric circles of personal connections, it's been months since I've been directly touched by severe cases of COVID. That's a radical change. All of these points suggest that, yeah, the pandemic could be over, and we wouldn't know. We wouldn't know because we're going to continue to find cases for quite some time, because we're out there looking for them, and we're finding them especially in young people without symptoms. We wouldn't know because we will continue to report some number of deaths. Remember, in Sweden, it really does look like the pandemic is reliably over. They had no lockdown. Everybody was exposed, and yet they're still reporting deaths. And they probably will be for some number of days or weeks. We certainly will be for some number of days or weeks. But if those deaths are occurring in people who were infected weeks ago, the pandemic could be over and we would still be reporting those deaths. So, I don't know. It's going to be October 1. I think there are many signs suggesting, and I know you're not hearing this from many others, and I know you're subject to a lot of doom and gloom reporting that's saying, hey, a new seroprevalence study in dialysis patients says only 10% of Americans have been exposed. We're massively far from herd immunity. The sky is still falling. I don't buy it. The fatality rate cannot be an order of magnitude higher in Americans than in other populations around the world. That's absolutely implausible. And simple, basic, reliable math leads to the conclusion that we've had a massively high national level of exposure. And all of the trend data I'm seeing indicate, yes, this continues to circulate among young people who are congregating in all sorts of new ways. But everything looks to be improving. Is that a guarantee that we're out of the woods? Absolutely not. And so, unlike many people who've chosen to go all the way to one of the polls and either argue, no matter what the data seem to suggest, no, sorry, the sky is still falling, panic please, I will not do that. But I can't go to the other poll either and say, because I wish this were over, I'm going to guarantee that it is. Because the fatality data from around the world don't quite fit our constructs here in the U.S., I'm going to argue that it's over and we've massively exaggerated the risk. No, I'm going to stick to the middle ground as I always have. I could be wrong about the pandemic being over. We may see a surge in cases. We may see an effect of a seasonal transition as we congregate more inside, as people are less careful, as we experience pandemic fatigue. But I don't really think so. I don't think we're going to have a major second wave. I think the major burden on the health system has come and gone. I think mostly what we're seeing now is insignificant transmission among people not prone to severe infection. I think we have exaggerated the risks of severe infection and death in the United States by an order of magnitude because we've been wrong about the denominator from the start. And my simple calculations lead to the conclusion that we may be at 71% immunity. Not perfect immunity. The people who had mild infection are not perfectly immune. The people who have native resistance from prior coronavirus exposure are not perfectly immune. It's still possible to get this infection, but it's not likely. That's good enough. And with 71% immunity to one degree or another, this virus is burning itself out. I think we're there. How will we know for sure? Time. We need the clarity of hindsight. Only hindsight is 20/20, as the saying goes. And we need to be far enough out of the pandemic woods to actually look back on them with clarity. So there was no way, even if I was right about October 1, there was no way that on October 1 we were going to be able to see that with perfect clarity. I should have built that hedge into my original extrapolation, I suppose, to protect myself. But, honestly, I'm really just sharing my thoughts with all of you as best I can. I've got skin in the game too, right? I live here. I've got family. I've got 80-year-old parents. I've got a wife. I've got children. We're in this together. But I'm trained in epidemiology, public health. I am qualified. I'm trained in biostatistics. I'm qualified to read this literature, interpret it, and share my perspective with you. And that's what I'm doing. So I'm not going to pretend I'm sure when I'm not. And I don't need to be perfect. I'm not. I'm human. I can make mistakes. Maybe I was wrong about October 1. Maybe it's October 15. Maybe it's November 1. Or maybe we're subject to a big second wave. But all of the signs that I'm reading. And I systematically avoid being buffeted around by the news du jour because, again, what happens to capture the news media or social media is largely dictated by drama and titillation. I'm looking for the big numbers. I'm looking for the reliable numbers. I'm tethering my cart here to global epidemiologic data, the biggest sources of information we can get, the most reliable. And all of that tells me that if the pandemic is not quite over in the United States, we are well on our way. So stay careful, allow for the possibility that it's not over, but I absolutely do think there is reason to hope that it is over or nearly so, and let's wait for the perfect clarity of hindsight to know for sure.